Alright, so we are going to continue talking about serious inflammation. Last time we spoke, we talked about the mildest, serious inflammation being the mildest form of inflammation and characterized by the exudate of serum. And serum is just the protein filled, antibody filled stuff in the blood. So it's the plasma mostly. So this occurs in early stages of most inflammation. We can see this in pneumonia, and it's recognized as the proteinous material inside the alveolar space that only contains a few inflammatory cells. As inflammation progresses, these inflammatory cells then proliferate and make more in the fluid. However, if the disease is diagnosed early enough, the causative bacteria is eliminated, the serious inflammation is restored, and inflammation resolves and everything goes back to normal. So we see this in many viral infections. We can also see skin vesicles caused by the herpes virus, or perhaps the best example of serious inflammation. You can see them here on a child. These are filled with that proteinous fluid, so that high protein fluid, low antibodies. We also see this in autoimmune diseases affecting cerebral surfaces, typically are also serious inflammations. So serious pericarditis, so inflammation in the pericardium, which is the casing of the heart. Pleuritis or peritonitis is also characterized by the accumulation of clear yellowish fluids in those cavities. We can also see joint swelling secondary to fluid accumulation is typical in rheumatoid arthritis and is the most common autoimmune disease. We can also see blisters of the skin caused by second-degree burns are another example, and then the serous fluid is readily reabsorbable, and the cause of inflammation is estimated the lesions will eliminated. The lesions will heal without any obvious consequences. So this is one reason you don't want to pop any blisters that you get that have that fluid underneath it. They're there to help you heal. You can see down here we've got an image of that serious inflammation. Then we have fibrous inflammation, and this is characterized by exudate rich in fibrin. Fibrin's a protein that helps with healing. They form these long strands of polymerized fibrogenes, which is one of the largest plasma proteins. And it's one step in healing as well. Fibrous inflammation is seen in a lot of bacterial infections such as strep throat or bacterial pneumonia. We see in bacterial pericarditis, the surface of the heart is covered with this shaggy, yellowish layers of fibrin. I'm so sorry, English is... So you can see these long, thin spindles of that fibrin. Then we have purulent inflammation, and this is typically caused by pus-forming bacteria such as Streptococcus or Staphylococci. Pus is usually yellow, and it's composed of dead or dying polymorphic nucleophiles and necrotic tissue debris. We see purulent exudate also being rich in fibrin, called fibropurulent exudate, and then pus may accumulate as well in mucus or skin or in internal organs. You can see here we've got that exudate within the veins close to the heart. A localized collection of pus within an organ or a tissue is called an abscess. We see skin abscesses quite often. If anyone's watched Dr. Pimple Popper, she removes quite a few of those. The central portion of an abscess is a liquid or is composed of pus. In a chronic abscess, the wall of the cavity is composed of a capsule, and this consists of a fibrotic granule tissue. So when these abscesses aren't drained properly, especially if it's a chronic abscess, that wall has to be removed, or that abscess would keep filling with that purulent inflammation. Abscesses do not heal spontaneously and must be evacuated surgically, so that cavity or that wall, they can remove it. Large abscesses tend to rupture, forming a sinus or a fistule. A sinus is a cavity usually occupied previously by an abscess that drains into a tract onto the surface or of the body. So like this would be an abscess that ruptures on the top of your skin and it drains outwards. A fistule is the Latin meaning for tube, and it's a similar canal formed between two pre-existing cavities or hollow organs, or between hollow organs and pre-existing cavities and the surface of the body. So this would be going outwards instead of, going inwards in between instead of going outwards. So here we can see an abscess on the brain that has to be surgically removed. Obviously this patient died, most likely due to the abscess as well as other complications to it. Ulcerative inflammation is inflammation on the body surface or mucosa of the hollow organ, such as the stomach or intestine, that may result in an ulcer or loss of esophageal lining. So this is stomach ulcers are an ulcerative inflammation. An ulcer is defined as a defect involving the epithelium, but may extend to the deeper connective tissue walls. A peptic ulcer typically occurs in the stomach or the duodenum. Then we have pseudomembranous inflammation. Pseudomembranous inflammation is a particular form of ulcerative inflammation that is also combined with fibropurulent exudate. So the exudate of fibrin, pus, cellular debris, and mucus forms the pseudomembrane surface on top of the ulcer. So you can see the ulcer here and that pseudomembranous yellow covering around it. For example, Clostridium difficile causes pseudomembranous colitis. So this is an ulcer and a pseudomembrane around in the colon. This bacterial overgrowth, which is secondary to the intake of a broad-spectrum antibiotic, may infect the large intestine. And these pseudomembranes can be scraped away to expose the ulcerative defect that would probably bleed profusely. We can also see these formed in the throat with diphtheria, which was a previously lethal childhood infection. Then we have granulomatous inflammation, and this is a special form of chronic inflammation that's not typically preceded by an acute inflammation. So a great example of this would be tuberculosis. That is a granulomatous inflammation. You get the infection and then you start forming granules in your lungs due to that bacteria. It may be caused by antigens that invoke a cell-mediated hypersensitivity reaction. That's exactly what we see with tuberculosis. These are typically formed in tuberculosis, but are also found in other tissues that are infected with fungi. So we can see histoplasma, casmosis, blastosoma, dermatitis, and others. We can also see them advance in advanced stages of syphilis, and these are gumnos. Granulomas reactions are formed of macrophages, T lymphocytes, and dead cell debris. These cells accumulate at the site of injury and typically encapsulate themselves in that area. The granulomas of tuberculosis and other infectious granulomas are often associated with central caseous necrosis. So we're going to see that cheesy exudate encased in a area. In contrast, the immunological mediated granulomas of sarcoidosis do not show those central caseinated necrosis. These granulomas will destroy the tissue and tend to persist for a long time, are super hard to treat. Clinicopathic corrections, so classic symptoms of inflammation, still most important local findings, and these are still the most useful indicators in diagnosis for inflammation. For example, acute inflammation of the nail fold presents with redness, swelling, warmth, and pain. Movement may also be limited due to pain. You're looking at an ingrown nail. When we're seeing symptoms like this, we're going to start being able to characterize those diseases. Similar symptoms could characterize an acute attack of appendicitis, but this organ is hidden from sight. So symptoms cannot immediately be recognized, but we're going to start seeing a swollen hyperemic appendix that's producing pain, so you're not able to walk. The time of operation, you're going to see that appendix being swollen, red, warm, about to burst. So, now that we've talked about different types of inflammation, we're going to go over and move on to healing and repair. So, acute inflammation typically heals without any consequence, or we can see it move on to chronic inflammation in some cases. We also have mild inflammation, once again usually responds and resolves spontaneously after the inciting stimulus has disappeared and the mediators of inflammation are no longer being secreted. However, if inflammation was accompanied with considerable destruction of tissue, complete healing may be postponed and never truly accomplished. Tissue loss complicates healing, but it's going to drastically differ between organs. Primarily, what's going to make this so dependent is the nature of the cells forming those different organs. So we have 3 groups of cells that can be healed or that we are going to want to be able to classify. So we have continuously dividing or mitotic cells, which is going to be skin cells, quiescent or facultative mitotic cells, and these are cells that have to be told to. And then we have non-dividing or post-mitotic cells, and these are cells that will no longer divide. So once they have gone and died, they will no longer come back, like nerve cells and muscle cells. So continuously dividing or mitotic cells, these cells divide throughout their entire lifetime. They're known as stem cells and are found in the basal member of your skin and mucosa of the organs. They divide at a regular rate, giving rise to more differentiated cells so that they can replace any dead or dying cells that are on their way out or have been moved and cleared out of the way, so that you're not losing sheets and sheets of skin without replacing them. Facultative mitotic cells do not divide regularly, but can be stimulated to divide if necessary. So we're talking about premotorial organs, like the liver. After a partial partial removal of the liver, we can stimulate the remaining liver to enter mitosis by dividing and replacing the loss. So you can lose about 40% of your liver and still replace it. Don't recommend doing that, but your body can repair and heal that missing liver. Now, our post-mitotic cells, or our permanent cells, these cells will not ever and do not have the capacity to proliferate under any circumstances. And these are going to be our neurons and our myocardial cells. So once a post-mitotic cell is lost, it cannot be compensated for. So we cannot fix it, we cannot repair it. All that's going to happen is we're going to replace it with some fibrous scarring and move on in that cardial cell area. A loss of neurons is irreversible, so if you've lost a neuron maybe in the lower portion of your spine, you're going to see paralysis, lack of feeling, so on and so forth. So cells that participate in wound healing are going to be leukocytes, macrophages, connective fistular cells, myofibroblast, angioblast, and fibroblast. Examples: cells in context of the following skin incisions. So PMNs play a brief role in scavenging the initial wound. The macrophages are the most important scavengers, and they're going to come in and clean up the rest of it. They then produce cytokine growth factors and mediators on other connective tissue. And these are going to start stimulating different cells to produce different things, so wound healing can begin. So the first thing that will come in as myofibroblast, as their name implies, they are a hybrid that perform hybrid properties of smooth muscles and fibroblast. This enables them to connect and secrete a matrix substance. So it's almost like your body's stitches. So they're going to come in and secrete that matrix to start pulling things together. The contractions of these fibroblast occurs within the first steps of the healing to reduce the distance and holds of the margins of the tissues to close them. This then enables the proliferation of the epithelial cells to cover the surface defect and restore the integrity of the surface. Angioblasts are the precursors to blood vessels, so they proliferate several small blood vessels at the margins of the wound so we can get blood to that area. They typically appear 2 to 3 days after the incision, and by the fifth or sixth day, the entire field of the wound is permeated with newly formed blood vessels. They serve two functions: to provide a route for scavenger cells to remove the scraped tissue and debris. They allow the influx of blood and nutrients. Then fibroblasts, these are cells fuel for producing most of the extracellular matrix components like fibrin and collagen. Fibrin is important because it also forms that scaffolding. So once that matrix is in place and we've pulled that skin close, this is like scaffolding to build that building back up. It provides tensile strength, so the ability to keep that plate, it's kind of like glue. It's going to hold that glue and other substances together to keep that skin nice and tight so that healing can occur. So then collagen forms fibrils in the interstitial space. I don't know what's going on with this slide. We're going to just move on. So in clinical wound healing, this is healing of a sterile surgical wound site by first intervention. So the scab is invaded by PNNs. Once again, they are then replaced by macrophages, which secrete cytokines and growth factors to promote the ingrowth of the myofibroblast, angioblast, and fibroblast. And we're going to finally talk about some complications of wound healing, which are scars, which are keloids. And these are scars composed primarily of type 3 collagen, typically called an immune scar, rather than type 1, which is what normal scars are made of. We can also see large scars heal as keloids, especially those caused by skin burns, tend to be irregular shapes, which can give rise to some contusions. Contusions over joints may impact immobility, impact and even immobilize the extremities. So if you've ever seen someone with severe third-degree burns over their hands or their arms, you're going to see those ridges and shapes where that skin has healed, and that can give rise to some immobility. And that's all. Thank you.